Today we're going to move on with the cutaneous senses. We're going to talk about pain. Usually people have a lot of, they can relate very well and kind of think back to times when you were in pain, unfortunately. But it is interesting, and it's fascinating to learn about this experience that we have. We are going to talk about a specific kind of pain, nociceptive pain, caused by activation of the nociceptors. So we've talked about several sensory receptors at this point. For vision, it's our rods and cones that take that environmental information and turn it into electrochemical information. For hearing, it's our inner hair cells, and we've talked about various mechanoreceptors for allowing us to feel pressure on the skin, vibrations, and so forth. The nociceptors are our sensory receptors for pain, and they respond to extremes of heat and cold. They respond to chemicals, and then severe pressure, stabbing, those kinds of pain, which means we are ignoring different kinds of pain as well. There's inflammatory pain. So when we do have damage to the tissue, this sometimes causes inflammation. We sometimes have inflammation to our joints. We have inflammatory pain caused by tumor cells, and we won't be talking about those kinds of pain. Neuropathic pain, we have damage to the nervous system or lesions to the nervous system, and for the most part, we won't be talking about neuropathic pain. One example of neuropathic pain is carpal tunnel syndrome, but another example is this phantom limb pain, and I will be talking about that, and I'll make sure to caveat that. I think I usually remember to Goldstein talks about that as if it's nociceptive pain, kind of when he's talking about the gate control model, but the gate control model really is attempting to address all of these kinds of pain. But for the most part, what we will discuss is nociceptive pain, so what's really happening because of activation of the nociceptors. In the 1950s and early 60s, the model for pain was called the direct pathway model, which just stated that pain is caused by signals sent from the nociceptors to the brain. But we know that it's more complicated than that, and even back then, they knew it was more complicated than that, but that was just the model that was available in the 50s and 60s. Again, we have known throughout time that there is not this really direct relationship between how large a wound is or the extent of a wound and the amount of pain a person feels. But this direct pathway model came out as a kind of straightforward way of talking about pain in the 50s. And so now is when they started collecting hard evidence to say, well, this doesn't actually appear to be a really direct relationship. And one of the first people who collected this evidence was Dr. Henry Beecher in 1959, who was a doctor at the hospital at Anzio Beachhead. And he claimed pain can be affected by a person's mental state. And when I first saw this, I assumed, and some of you might assume this has something to do with adrenaline. Soldiers who are out on the field, people who are in situations where they are in peril, or people they love or know or are close to are in peril, they're going to have a rush of adrenaline and not really feel a lot of pain. That is not what this is talking about. This is talking about the people, the soldiers who were at the hospital, and in order to be brought to the hospital, they had to have some pretty extensive wounds. So compound fractures of a long bone, penetration of the head, chest, or abdomen, and it had to be pretty extensive tissue damage for them to be taken off of the battlefield. What they found was that of the 215 patients who were mentally clear, not in shock, and able to communicate, they had 69 of those 215 patients said that they felt no pain at all. And of those 215 patients, 58% said they either had very slight pain or no pain. So that we have 58% of the people saying they're not really feeling very much pain at all when they have pretty extensive wounds. So what's going on there? He assumed, Dr. Beecher suggests, that what's happening is these soldiers were so relieved. So if you look at what was happening at Anzio Beachhead, this was one of the Italian campaigns, and this was a battle that lasted almost 5 months where there was bombing, and it was in marshland. It was miserable. And so the assumption was that these soldiers were so relieved to be in the hospital, to be alive, and to be out of peril, that they just didn't, that mental state influenced them to not really feel a lot of pain. I will say a little bit of my assumption is also that there might be for some of those soldiers, some survivor's guilt, as if you know how soldiers feel about their other soldiers out there, they often feel like brothers in arms, and they probably maybe felt some guilt about the people who are still in the battle. So there's probably a mixture, but the whole point is pain can be affected by a person's mental state a great deal. We also know that pain can occur when there's no stimulation of the skin. So if we look at people who have phantom limbs, so if someone who has an arm or a leg or a hand or a finger amputated, so they have some part of their body that has been amputated, that part of the body is no longer there, and yet sometimes they feel pain in that part of the body. Many people who have an amputation have a feeling of a phantom limb. So when they're walking, they might feel like their arm that's been amputated is moving along with them, like it normally did. When it's not, people with a missing leg sometimes get up out of bed and act as if the leg is still there when it is not. So there's this sense of a phantom limb, and about 30% of people feel pain in their phantom limbs. So there's no stimulation of the skin, and they at some point thought that this was still the nerve endings that were experiencing some stimulation and so feeling pain, but they have gone in and cut those nerves, severed those nerves farther up to get rid of that possibility, and those people still felt phantom limb pain. So here we have pain when there is no stimulation of the nociceptors at all. Also, pain can be affected by attention, and I'm going to read this anecdote, but I'm going to tell you to go ahead, and we've all experienced this kind of experience. So again, I usually have a student read this, but here we go. This is from I can't remember, one of Goldstein's students. He says, I remember being around 5 or 6 years old, and I was playing Nintendo when my dog ran by and pulled the wire out of the game system. When I got up to plug the wire back in, I stumbled and banged my forehead on the radiator underneath the living room window. I got back up and staggered over to the Nintendo and plugged the controller back into the port, thinking nothing of my little fall. As I resumed playing the game, all of a sudden I felt liquid rolling down my forehead, reached up my hand to realize it was blood. I turned and looked into the mirror on the closet door to see a gash running down my forehead with blood pouring from it. All of a sudden I screamed out, and the pain hit me. My mom came running in and took me to the hospital to get stitches. Ian Kalinowski. So, and again, we've all had that experience of you hurt yourself, maybe pretty badly, and you really don't even feel the pain until you see the evidence that you hurt yourself. And that has to do with attention. So when we didn't realize that we should be in pain, we weren't paying attention to the pain, we were not feeling the pain. So all of these examples and this kind of information and this kind of evidence led Ronald Melzack and Patrick Wall to introduce the gait control model of pain. In the gait control model of pain, which was introduced in 1965, pain signals enter the spinal cord from the body and are transmitted to the brain, but additional pathways can influence this signal. So they can, in effect, open or close a gate located in the spinal cord, which then it's not just the pain signals, the nociceptors themselves, but it's which gates are open and closed and how much that determines then the strength of the signal leaving the spinal cord and communicating to the brain. If you remember what I did in class, I usually talk from pictures and then go back to the words, but I wanted to just read the words so that because I can't go back the way I usually do. But here's the gate control. On the left is picked a basic picture of how the gate control model would work. Okay, so if you see the big T cell, that's the transmission cell, and that's going to be the cell in the spinal cord that's going to take the information to the brain. If we look outside of the dashed box, the S fiber, so information coming from the nociceptors. Nociceptors, if you remember way back to the beginning of the touch lecture, they're small fibers. Okay, so the nociceptors are going to be S fibers, and they are going to communicate excitatory information directly to the transmission cell, and excitatory information directly to the substantia gelatinosa. So that Sg positive, you don't need to know the name substantia gelatinosa, but there it is. That is in the dorsal horn of the spinal cord. So these dorsal roots are coming in. If you remember, my touch and pain, my incoming information is coming in those dorsal roots. And if I'm a small fiber, I'm communicating to the substantia gelatinosa, which is also communicating excitatory information to the transmission cell. So nociceptors are going to be excitatory, right? As they are sending that information that we are in pain from whatever, chemicals, heat, cold, pressure, stabbing, all of that. We also have large fibers, okay? Those mechanoreceptors are also communicating. They can communicate excitatory information to the transmission cell, but they're also communicating excitatory information to inhibitory substantia gelatinosa. So the Sg minus and the redness there is all indicating that this is going to communicate inhibitory information to the transmission cell, effectually closing a gate. So my nociceptors are going to open the gates and tell me I'm in pain, but my large fibers, part of what they're going to do is close the gates to pain. Now, large fibers do a bit of both, as if we are actually touching the mechanoreceptors that are in the same exact place, they are going to, that's going to create some pain. But remember, we have those excitatory, inhibitory center surround receptive fields that if I can be around and in the same area, I can be sending inhibitory information. And if you think about it, this is what our mothers are doing, maybe without knowing the science behind it. But when we fall from our bike or bump our elbow and we're in pain and they come up and they rub our arm nearby where the pain is, they are basically sending this inhibitory information. What mothers probably think is this just feels soothing to my child, which is also true. But what they are doing is they are stimulating those large fibers, those mechanoreceptors that are communicating to the inhibitory substantia gelatinosa that are closing the gate for pain. If you notice also what we have at the top outside of the dashed line is central control, or what I'm going to probably accidentally call many times cognitive control. So we also have our brain that can communicate down to the inhibitory substantia gelatinosa to close the gate of pain, whether that be my attention is somewhere else or my mental state is such that I can close the gate to pain. Okay, that is the gate control model. I have here the ascending fibers from a different book. You don't need to know on the right-hand side, but I like to have the picture because to me it's more informative of, so I stub my toe or hurt myself there, and that information is going through the dorsal roots to the spinal cord. It crosses over contralaterally at that vertebra in the spinal cord, and it's going to travel up the spinothalamic pathway there and to several areas of the brain, starting with the thalamus. Okay, and that's again just there for reference. And I remember students asking me about, do I need to memorize all this? I put those extra pictures there to help you. And I know maybe they don't, but if they don't help you, just cross it out in your mind and say, I don't need to know that. I'm just trying to help you envision all of this. Okay, if you ask me at this point, and what I usually say is that cognitive control And I'm going to keep talking about that cognitive control as being much more complicated than just sending potentially inhibitory information. Okay, there are times when we have acute stress or chronic pain, or there are times when we are paying more attention to pain, where I feel like cognitive control can have an excitatory influence on our pain and open a gate to pain. I do feel like the gate control model needs to be updated. And at the very beginning, when I talked about your projects and I talked about updating a model, this was the kind of model. What I meant by updating a model and creating a model is not just creating this model, but to update it somehow that makes sense. But you want to think about how would I update this in my brain? Because again, this was um, um, I'm not stopping now, suggested in 1965 or proposed in 1965. And while there have been lots of studies, and we're going to see some studies where there's evidence that things are more complicated, there hasn't been a newer formal model clearly proposed since the gate control model. This is still how they often talk about how we experience pain. So I'm going to talk about cognitive control for that central control bubble for a little while here when I talk about cognition and pain. And again, I think it's a little bit more complicated than just that we're going to have excitatory information sent to inhibitory substantia gelatinosa, closing the gates of pain. But you can think about the examples and think about your own examples and what you think. So I'm going to start with this expectation, the hospital study where patients were told what to expect, that they were to expect not too much pain, and they were told to relax. And those patients were sent home 2.7 days earlier and requested fewer painkillers than patients who were not provided this information. So if you know what it's like to be in a hospital, sometimes they are not really providing you with information about what to expect. I sometimes get the question here because this really was about, they were told to expect not too much pain, that people ask me, well, what about when you're expecting a lot of pain and someone's built up? So for example, getting a tattoo or getting your ears pierced and people have told you this is going to be really painful. And then when you go to do it, there's this, you don't have a lot of pain. Well, their expectation influences us in interesting and complicated ways. I think it deserves a lot more examination, and I don't have an easy answer to that except potentially expecting a lot of pain and then having not as much, or having something happen really quickly like your ears pierced. That might be a relief. What the point here was, this was compared to people who were not provided information at all. So not really knowing what to expect, I think, makes things worse. But again, I think that there needs to be more research to examining, or I need to read more research examining how exactly expectation influences our pain, because I think it's pretty complicated. The shifting attention. So in this particular hospital study, they are now using this virtual world, these virtual reality games to shift people's attention from pain. But one of the original studies came from a hospital study where they were working with a man named James Picorni, I think his name was. He had third-degree burns over 42% of his body. He was working on a truck and the fuel tank exploded. And if you have ever seen somebody be debrided, so there were times when and I think I actually discussed this one of the first days of class as we talked about why study sensation and perception. But if you've seen somebody be debrided, they have these bandages that are really stuck to their tissues and their blood vessels and so forth, and because there is no skin there. And so when they're pulling those bandages off, it is extremely painful. And what they did was they first performed this as usual, so just debriding him, and he rated his pain as very high. And then they debrided him once when they put him in a virtual world. And this was even a really boring video game, but in a virtual world where you're really put into the feeling that you're in this world. And all he had to do was to chase a spider into a disposal and grind up the spider. And when the spider was ground up, another spider would come and he would chase it into the disposal and like in the kitchen and then grind up the spider. So not even a fun game. And yet he rated his pain as much lower than when he was not having his attention shifted in this manner. And so now they have found that putting people in a virtual world, some kind of virtual reality game, is much more helpful for relieving people's pain than even video games or other distractions that they've found. David and Verbatim suggest that even the content of the emotional distraction is important. So they had participants look at positive pictures, neutral pictures, or negative pictures. And those participants immersed one of their hands in freezing cold water. They were told to keep their hand in there as long as possible, but to withdraw the hand when it began to hurt. So this was going to be cold water that would cause some pain. I'm going to do a little bit of description of these positive, neutral, and negative pictures because I think it's interesting, funny, and I've actually had one of my students say, wait a minute, there's a confound there. So I'm going to quickly discuss that too. So this was all done. First of all, the pictures were rated by males, and then this was all done with males. So this was all men, were all the participants. And the positive pictures were either pictures of attractive females or sports cars that other males said had a positive influence on them. The neutral pictures were, I can't remember some of them, but maybe furniture, but nature. One of them included nature. So these are neutral pictures. I actually think nature is pretty positive in my mind, but these guys were rating nature as neutral. And then the negative pictures were things like pictures of bloody gore and burn victims and things that we would all agree are negative pictures. And what you can see in the data, so in the figure over there, is that if they were looking at the positive pictures, they could hold their hands in the freezing cold water for longer than if they were looking at the neutral or the negative pictures. And there is no indication in your textbook whether there was a significant difference between those neutral and negative pictures, and I would have to go look that up. It looks pretty close, but whether there is or not, we can say the positive pictures allowed people to experience more potentially painful stimulation without feeling pain as they were leaving their hand in there for longer. However, the confound that my student pointed out was if these are males and they are looking at attractive females and sports cars, again, not really sure that this is going to have an autonomic nervous system response, but they might have some autonomic nervous system response. So it's not just something that's positive and soothing in a good way. This might be influencing the autonomic nervous system, which we already knew has an influence on pain. Again, not necessarily a confound for overall emotional distraction, it's complicated. But in the very next slide, I'm going to come back to emotional distraction. We're going to see another really good example that works a lot better, I think, in some ways. Okay, in this study by Roy et al., what they were doing was they had a potentially painful, so a heat stimulation on the forearm that would cause some pain, and they had people rate their intensities of pain, the intensity of pain, and the unpleasantness of the pain, and they had them in one of three conditions: either silence, listening to unpleasant music, which I'll complain about in just a bit. It is Sonic Youth, and I like Sonic Youth, but I have listened to this song because I was curious. It was pendulum music. I did not know that song. It is really odd and maybe has some unpleasant sounds in it, but it's interesting. And you might think, what about people who actually like that kind of music, which I'm going to talk about in a second, or pleasant music. So this was Rossini's William Tell Overture. And what you can see is clearly the unpleasant music had the effect that they assumed it would have, and to some extent, as whether the people were in silence or listening to unpleasant music, they were rating their intensity of pain and the unpleasantness of pain as pretty high. They were up near 60 or 70 from a scale of 0, no pain, to 100, extreme pain. They're pretty high in their ratings of pain. And we see lower ratings for the pleasant music. So for the Rossini, the William Tell overture, which I've also listened to, it's pretty. It has some soothing parts to it, where they're rating their pain as much lower, and their unpleasantness of pain is even under 50. So it's getting to where their pain is not really as annoying to them. I will say that the data go in the correct direction, and so we might assume that most people experience the unpleasant music as unpleasant and the pleasant music as pleasant. Again, this is where I often get a lot of students asking questions because we don't all think that the same music is unpleasant or pleasant, but this clearly had the influence that the researchers were looking for. We still see the significant effects of the pleasant music at the very least. So this also suggests, if we go back to that earlier content of emotional distraction, this suggests that those positive pictures, maybe it wasn't all just autonomic nervous system response. We really are feeling less pain. Not just that it's less annoying, but it's less intense when we are in some kind of positive distraction or more positive mood, however we look at it. My last example of the influence of cognition and pain, or the influence of that central control and cognition, is this hypnosis study. I used to have one more, but I've moved it for various reasons that I'll explain when I get there. But this hypnosis study by Derbyshire et al. In 2004, they had participants rate their experience of pain from 0 to 10, so no pain to extreme pain, in 3 conditions where they really induced physical pain, so they had heat impulses delivered through a stimulator. Hypnosis-induced pain, so where the experimenter suggested that painful heat was presented, but in fact the stimulator was touching their skin, but it was not turned on. And then a control condition under hypnosis, the experimenter told the participant that the stimulator was indeed turned off, but that he or she should imagine that painful heat was presented. Okay, for physically induced pain, they're rating their pain at 5.7, so a little bit higher than basic medium. So for hypnosis-induced pain, there is a rating of 2.8, which this is showing that we can have some excitatory influence of cognitive control, because if we look at the control condition where they are told the stimulator was turned off, but he or she should imagine that painful heat is presented. Some reported feeling heat, but none reported feeling pain. So this 2.8 is higher than not being hypnotized and convinced there's pain at all. So there's something else to think about, and where you think that cognitive control component, how you think that's working.